and good evening to all the participants, respected teachers and dear participants. Today, we are going to present our lectures on accessory pathways, and our speaker is respected Professor Mohsin Hussain sir. Now, I request Professor Abdul Wahid Chaudhary sir to say some words about Professor Mohsin Hussain sir, introduce him, and then we start the lecture. Abdul Wahid sir.
ওয়াদুদ ভাই নাই?
শুনতে পাচ্ছেন স্যার?
এটা ওয়াদুদ ভাই আসুক আগে। ওয়াদুদ ভাইকে আনমিউট করে।
আনমিউট করা।
কথা শোনা যাচ্ছে?
এখন শোনা যায় ওয়াদুদ ভাই, এখন শোনা যায়। হ্যাঁ,
এখন শোনা যাচ্ছে স্যার, এর আগে শোনা যাচ্ছিল না স্যার।
Assalamu alaikum and good evening everybody. Sorry for the technical problem. Today we are going to have a talk about accessory pathways, and this will be given by Professor Mohsin Hussain. He is one of the three persons who heralded the electrophysiology service in this country, starting with Dr.S.M.Rahiduzzaman in the private sector, and then starting very ably Professor Atahar Ali and Dr. Mohsin Hussain under the close supervision and tutelage of Dr. Rafiq sir. And we have come quite a distance in these last few years, starting from 2004, when they started doing it in National Institute of Cardiovascular Diseases. Professor Mohsin is working there as the head of the EP division, and he has also started doing the 3D EP study, and also different complicated ablation procedures. He is doing it very ably, and they are also providing very good service regarding the ICT and CRTD implantation. Without much ado, I would ask Professor Mohsin Hussain to start his lecture, for which we are eagerly waiting. Professor Mohsin, the field is yours.
Assalamu alaikum. Good evening, respected teachers, dear panelists. I am going to present my talk. I am now sharing my screen.
Mohsin, কথাটা কি একটু পরিষ্কার করা যায়?
এখন শোনা যাচ্ছে স্যার?
হ্যাঁ, বেটার।
Slide দেখা যাচ্ছে স্লাইডটা? Can you see the slide?
Very well.
Can I start now?
Yes, please.
Respected teachers from home and abroad, and their panelists, and Assalamu alaikum. Good evening. I am going to present a talk on accessory pathways and related arrhythmias. There will be some overlap between the previous lecture, so I'm now starting here. You can see here how this sinus rhythm is formed, and the normal activation starts from the SN node. You can see here, and goes to the AB node and through the backbone bundle to the left side, and his bundle Parkinson system, whole of the ventricle is depolarized. You can see here in the left side, you can see here there's a pair interval, the AB delay, and sometime in exam it asks for the students or the MD students, the asked to draw the his electrogram. You can see here the left side there is a, and in the middle in the sharp signal in the his, and the B in the letter one. The A is B, and A is and HB together contribute the PR interval. So this is the AH interval and HB interval. So AH and HB is together we call PR interval. Accessory pathways usually at the abnormal conduction pathway, usually formed during the cardiac development, exist in the variety of anatomical location, and in some patients they have multiple pathways. In WW accessory pathway, it is often referred to as bundle of 10 because he had invented this pathway and also known as atrioventricular bypass tract. That is connection between the atrium and ventricle. Wool-Parkinson-White syndrome is described by these three persons in 1930, and it is a combination of presence of pathway and episodes of tachyarrhythmia. Both is called the WBW syndrome. If there is no tachyarrhythmia or syndrome, it is called WBW pattern. So in ECG, we can write down only WBW pattern. If there is a documented tachyarrhythmia, so then we can call it WBW syndrome. Prevalence is 0.07 to 0.02%, and 1.8% of this patient develop tachyarrhythmia. WBW pattern prevalence is 0.013 to 0.25%. And there is a small chance of because of patient who develop atrial fibrillation and ultimately develop atrial fibrillation, and a percent is 0.13% per year. So patients who are developed atrial fibrillation, so they are very risk for developing sudden cardiac death. This is the typical ECG pattern of the WBW syndrome. In the left side, you can see here the normal PR interval, QRS complex, QF upright. In WBW syndrome, the PR interval will be short, clearing of the initial part of the QRS and the negative complex and ST and TOF. So this is called the PR interval or short PR delta wave and inversion. So this is called WBW ECG pattern. And some posterior septal region, they did angiogram, and because of they thought it is into MI, so the coronary was normal. And this is the location of the accessory pathway. But types we can see here is the atrioventricular accessory pathway, most common pathway.
তোমার এটা এখনো শিফট হয়েছে এতক্ষণ পরে।
You can see here the types of the accessory pathway or location of the accessory pathway. We can see the most common is the atrioventricular connection is the most common pathway. The next common is the atriovesicular pathway, and then is the atriohesian pathway, and then is nodoventricular pathway. We node to the ventricle, nodoventricular pathway, and is the vesicular ventricular pathway. So most commonly we found in the atrioventricular accessory pathway and produce variety of arrhythmia, and sometimes we find in the atriovesicular, that is called Mahim fiber, and the rest of the very rare, but my from 2004 till now we don't get any atriohesia or nodoventricular or vesicular ventricular pathway. So but it is present in literature review. There is a lot of patient because atriohesian pathway is produced, looks like AVNRT or is as a bystander pathway, and vesicular ventricular is mainly it is asymptomatic, but the nodoventricular pathway produce white complex tachycardia. The conduction properties of the accessory pathway most manifest accelerated pathway, there is a delta wave present, and usually the conduction is bidirectional, both antegrade conduction, mainly atria to the ventricle, and retrograde conduction, mainly ventricle to the atria. Both may present, only antegrade, mainly atria to the ventricle, antegrade conduction, or only retrograde, mainly ventricle to the atria. And concealed axillary pathway, they don't have any antegrade conduction, they have only retrograde conduction. So in this concealed axillary pathway, we don't have any delta wave. But in patient with documented tachycardia, we got the tachyarrhythmia, and during EP study we can find the axillary pathway. But 12 ECG, we don't have any signs of axillary pathway. How it locate location of the axillary pathway? If the mitral annulus and the tricuspid annulus at this level, pulmonary valve in the front and the AV valve, this is the septum, and this is the mitral valve annulus and the tricuspid annulus. So if we divided the mitral valve the left side, this is the mitral valve left free wall pathway, and on this is the postseptal pathway, the septal region. This left side is the left postseptal, right side is the right postseptal pathway. And subdivision you could do left trivial, anterolateral, lateral, posterolateral side. This is the atrioventricular connection. This is the trivial pathway. And the left side, we have the left trivial, right trivial pathway, and right postseptal pathway. Another is the right side, the anteroseptal pathway, very close to the AV node. So these are the location of the axillary pathway. By ECG, we can locate the where is the pathway is located. We can identify from the there is just some algorithm. I will show you later on. In the left side, this algorithm I brought from Brunel textbook of cardiology. Here it is being that how we can localize the location of the pathway. First, the negative delta wave and QRS complex. If the negative delta wave in the V1, then it is the right ventricle. If the negative positive delta wave in the V1, so it is left ventricle. Then we divided in the two sides. If the 2-3 AVF is negative, then it is postseptal. If the 1 AVL and V5, V6 is isoelectric or negative, so it is left lateral pathway. So left side only 2, left trivial and left postseptal pathway. And right side where if the 2-3 AVF is negative, so it is right postseptal pathway. If the 2-3 AVF is positive, so it is anteroseptal pathway. And in between there is trivial and midseptal, there is a left axis deviation. In this case, it is called the right trivial or right midseptal pathway. So if the V1 is negative, it is right-sided, 2-3 AVF negative, postseptal pathway, 2-3 AVF positive, it is anteroseptal pathway. If the left axis deviation is a right trivial or right midseptal pathway. And left-sided, if the 2-3 AVF is negative, left postseptal. If the 2-3 AVF positive, 1 AVL negative, is a left trivial. But there is no left-sided anteroseptal pathway because of the aortic valve or aortic root. So how the it looks like the pathway. There's animation. You can see here there's a conduction both from the sinus node, its growth from the AV node, and the axillary pathway. You can see here it depolarizes the both ventricle. So they produce the initial delta, short PR, and fusion beat. So you can see here the impulse coming from the AV node, it goes both through the AV node, and as well as the axillary pathway, and they fused, and this is called fusion beat or delta PR, short PR, delta. This is the location of the bundle of current or atrioventricular connection. This is the left-sided pathway. You can see here V1, there is a short PR, delta wave, and initial sliding. V1 is positive. If the V1 is positive, so it is a left-sided pathway. 2-3 AVF is negative, so it is left postseptal pathway, the left-sided pathway. And here you can see the V1 is negative, delta wave negative, so it is right-sided pathway. 2-3 AVF negative, so it is left, right postseptal pathway. So V1, if the V1 is positive, it is a right-sided pathway, left-sided pathway. If the V1 is negative, it is left-sided pathway, right-sided pathway. And positive, it is left-sided pathway. And now the arrhythmia associated with the WBW syndrome, most commonly 80% of the cases, it is orthodomic atrioventricular reentrant tachycardia. Mainly, the antegrade conduction goes to the AV node and retrograde conduction goes to the accessory pathway. So the QRS complex narrow. So this is called orthodomic atrioventricular reentrant tachycardia. It's produced 80% of the cases. And another orthodomic tachycardia is PGRT, that is permanent junctional reciprocating tachycardia. It mainly occurs in children. It is produced insistent tachycardia and produce cardiomyopathy. As this fiber is slowly conducting, so the rate is slow, 120 to 200. So it's produced insistent tachycardia, produced cardiomyopathy. So it is a one kind of that is orthodomic AVRT, but it is produced, looks like that is slow type tachycardia, most like slow, but it produces the tachycardia mediated cardiomyopathy. Mostly it is located in the right postseptal region. And pre-excited AF, when the WW, that fibrillation, it produces 15 to 30% patient, and sometimes it's desired to ventricular fibrillation, and patient will develop sudden cardiac death. Atrial flutter, literature said 5%, but I don't get yet this atrial flutter. Antidomic tachycardia, we got it, and less than 10% is attenuated tachycardia. Mainly antegrade conduction to the accessory pathway, so it activates the ventricles, so it produces white QRS, and retrograde conduction through the AV nodes. So the antidomic tachycardia, antegrade to the AV node, retrograde to the normal conduction pathway. So it produces white complex tachycardia, looks like ventricular tachycardia. These are the three forms: orthodomic fibrillation with WW and antidomic, and sometimes atrial flutter. These are the most common tachycardia we encounter with patients with WBW syndrome or accessory pathway. How it initiate? Initiate by the mainly by the ectopic beat. It is sinus beat. Sometimes you can see here the ectopic beat come and it's blocked in the accessory pathway and goes to the normal sinus beat and retrogradely goes to the accessory pathway. So the orthodomic AVRT is initiated by the always PSC. Atrial ectopic is the initiator. The atrial ectopic blocked in the accessory pathway, go through the AV node and his bundle and normal Parkinson system, and retrogradely goes to the accessory pathway. So it produces the narrow complex orthodomic atrioventricular reentrant tachycardia. You can see here, this is the antegrade conduction, and this is the retrograde through the accessory pathway. In endodermic, it is reverse. Endodermic goes to the this way, antegrade conduction, and retrograde to the AV node. So this is tachycardia, narrow complex tachycardia. PUF is previously discussed, is mainly in the ST segment. So it is most of the PUF we can see. By seeing the PUF morphology, we can also identify the location of the tachycardia also. Accessory pathway. And this is the most dangerous part, the atrial fibrillation. If the atrial fibrillation occurs, you can see here, this pathway, most of the pathway blocked in the AV node, sometimes goes to the AV node, so it's produced narrow complex. And when it goes to the accessory pathway, it produces white complex. So it's produced white, narrow, irregular, variable length. So it looks like that is polymorphic ventricular tachycardia, but it's irregularly irregular. And this patient is very rapid heartbeat is very rapid, and most likely this patient should get there is cardioversion or DC cardioversion to revert to sinus rhythm. This is the atrial fibrillation, and it can degenerate to ventricular fibrillation, and patient can go sudden cardiac death. And the treatment, curative treatment is the ablation of the accessory pathway. This is the, you can see here, this is the atrioventricular connection. This is the catheter, most of the catheter, each bundle catheter, right atrium catheter. This is ablation catheter. We can ablate the accessory pathway. So if we ablate the accessory pathway, you can see here, there is a delta wave. After ablation, there is a disappearance of the delta wave. So ablate procedure is the curative procedure of the accessory pathway. You can see here also the delta wave. You can see here after ablation there is no delta wave. There is loss of the excitation. So this is the after ablation, loss of the excitation. Now I have shown my some cases. You can see here 50 years old man presented with recurrent palpitation for several years in NICBD. This is the ECG in the EP lab. You can see here 12-belt ECG, the narrow complex tachycardia. It can be by seeing ECG, there is we cannot see in the POF, so it could be AVNRT or atrial tachycardia. So after after sinus syndrome, you can see here there is a delta wave in the B1 is positive, so it is the left-sided pathway. 3 AVF negative, so the left post-septal pathway. So this is the rhythm. EP study confirmed left-sided pathway. EP study confirmed this is left trial pathway. So these are the accessory pathway. After ablation, you can see there is no delta wave. Patient is fully cured. Another case, 35-year-old woman presented with recurrent palpitation. This is ECG. You can see here. This is white complex tachycardia, and B1 is LV morphology. 2-3 AVF positive. This could be ventricular tachycardia or there is differential diagnosis of the white complex SB2 with aberrant conduction or pre-existing left bundle or antinomic tachycardia. By seeing these criteria, we can find that this is the accessory pathway with rate-related bundle block. After sinus syndrome, there is a, you can see 2-3 AVF, you can click at the web. So it is WBW syndrome, mainly accessory pathway. The location is confirmed by the EP study. It was confirmed right free wall. This is the right sided. It is positioned the right free wall pathway. After ablation, we ablate the pathway. You can see here there is a normal clearance. There is no delta wave. So after ablation, this is normal. Case 3, 65-year-old man presented in the NICBD with recurrent palpitation and chest pain, history of recurrent hospitalization, white complex tachycardia, right coronary was 100% occluded, LAD and LCX was normal. This is presenting ECG white complex tachycardia. We thought it was ventricular tachycardia, but in the EP lab, we again they produced narrow complex tachycardia. So that was rate-related aberrancy. Actually, this patient has narrow complex tachycardia, and 12-belt ECG. There is, you can see here, there is unremarkable narrow complex normal ECG, and EP study confirmed there is a retrograde, that is concealed pathway. That is left free wall concealed pathway. That is there is no delta wave. Only they have the retrograde conduction from the ventricle to atria. The left free wall accessory pathway confirmed by the EP lab. We ablate the pathway and patient was very well. Another case, 19-year-old boy presented with emergency NICBD with palpitation, and he has pulse was very much irregular. BP was 100/70. Examination was normal, and in ECG looks like that. You can see here irregular, different with and white QRS morphology is the atrial fibrillation with WW syndrome. Differential diagnosis is polymorphic ventricular tachycardia. So after cardiovascular sinus syndrome, this patient has this. You can see here the delta wave in the ECG, but 2-3 AVL is positive. So in the localization after the EP study, we can EP lab they produce also narrow complex tachycardia. So it's confirmed it is produced the narrow complex tachycardia. Sometimes WW with atrial fibrillation. And we look at the pathway EP study, right free wall accessory pathway, right free wall it was located, and we frequently ablate tachycardia, and there is no delta wave. The patient is completely normal. And this is the one of the ECG I collected from the that is Melvin Steinman. He's presented this ECG from the 2008. There is a white narrow complex and white complex tachycardia different morphology. In left side, B1 is here, is LVB morphology, and here is RVB morphology, and there is some aberrancy, right bundle aberrancy, and this is the right bundle morphology. So it looks like polymorphic VT or pleomorphic ventricular tachycardia. So, or we can, it is a atrial fibrillation with multiple accessory pathway. There is WW with atrial fibrillation with multiple accessory pathway produce this left bundle, a right bundle morphology, irregular. This type of path ECG they can produce. And after cardioversion, there is a clean cut delta wave. You can see here, there is a clean cut delta wave. V1 is slightly positive and 2, 3 AVF is 2, sometimes isolated AVF positive. And so after cardioversion, after ablation, they found that there is a left side lateral and right lateral, both there is a both accessory pathway after ablation. So if there is a multiple accessory pathway, the atrial fibrillation can produce left bundle, right bundle, both irregular accessory pathway. It produce looks like there is polymorphic ventricular tachycardia. Another case, 40 years old woman referred to NICBD for evaluation for palpitation. And ECG shows the V1 is negative, so the right side pathway, 2, 3 AVF is negative, so the right post-septal pathway. And electrophysiology study and mapping showed is a right post-septal pathway. This is the right post-septal region. So we ablate successfully, and after ablation, there is disappearance of delta wave, and patient is cured. So location by seeing the pseudo negative delta wave in the V1. And S6, 30-year-old female presented with recurrent palpitation and chest pain. He underwent recurrent hospitalization, and every time he needs cardioversion. She also underwent 2 failed ablation. Clinical examination are unremarkable. His baseline ECG, you can see here, 12 ECG. There is no minimal pre-excitation. Looks like normal ECG. But in the EP lab, we induced this white complex tachycardia. This is left bundle morphology. It is the left axis deviation. If we found the left bundle morphology, left axis deviation, one of the differential diagnoses is myelin fiber tachycardia or atrial tachycardia. It could be ventricular tachycardia also. But if the left bundle morphology, left axis deviation, so we have to get in mind. So it could be myelin fiber tachycardia. So after during atrial pacing, gradually there is you can see the pre-excitation appear. So atrial pacing, there is a pre-excitation appear. So we thought that it is atrial or myelin fiber tachycardia. So during EP study, what complex tachycardia, 1:1 conduction, and ultimately within the EP study we confirm it is the atrial pathway or myelin fiber, and we ablate in the right post-septal pathway. There is a delta wave there, and ablation success in the this is the atrial pathway. Connection from the atria to the right bundle. So atria to the right bundle, so it produces left bundle morphology and a left axis deviation. So left bundle morphology, left axis deviation. Always you have to remember it could be myelin fiber tachycardia. Most of the myelin fiber tachycardia in the right post-septal pathway. During pacing, there is a pre-excitation, and after ablation, there is no pre-excitation. So it is myelin fiber tachycardia. So it's another important feature of myelin fiber tachycardia. If we put the ablation catheter in the atrial side, you can see the myelin potential looks like his bundle potential. So these fibers have characteristics looks like heavy node. Another case, 20 years old boy admitted in the NICBD with palpitation. And ECG we can see here, what complex tachycardia. So we thought it is ventricular tachycardia, and differential diagnosis is endodermic tachycardia, with aberrant conduction or pre-excited RV morphology. But after a normal sinus rhythm, you can see here cardioversion. This is a delta wave. You can see clean cut delta wave. V1 is positive and 2, 3 wave negative. So it is a left post-septal or posterolateral pathway. So this is the that was the endodermic tachycardia. This tachycardia was mainly endodermic tachycardia. Or so how we distinguished the endodermic tachycardia from ventricular tachycardia. Bugada algorithm we can use. In Bugada algorithm, if there is a negative concordance, that is pituitary lead B4, B6 is negative, so that was the ventricular tachycardia. If there is no, so you can see the QR complex in B1, B2 to B6. If the QR complex V2 to V6 is also ventricular tachycardia. If no, we have to look for the 1:1 conduction, that is AV decision. If there is AV decision, it is ventricular tachycardia. If there is no AV decision found, so consider the pre-accident WBW or endogenic tachycardia, or you need to EP study or sinus rhythm to see the. So in that case, how you can see here, this patient has white complex tachycardia, predominantly RBB morphology. In this criteria, we can see V4, V6, V4, V6. There is no negative complex, so it is negative complex. Or it is V5, V6. It is positive, so it is not ventricular tachycardia. Next step, we can see the QR complex in the B5, B6. B5, B6, no QR complex. So it is against ventricular tachycardia. And AV decision very fast, so it is very difficult to find out the AV decision, but there is no AV decision here. So also against the ventricular tachycardia. So consider the pre-accident SBT or that is endogenic tachycardia and cannot be certain. So EP study is the final diagnosis and sinus rhythm. And this patient has sinus rhythm WBW syndrome. So this patient has endogenic tachycardia. So with this algorithm, we can differentiate from the endogenic tachycardia from the ventricular tachycardia. Another case, 90 years old young man admitted in ICBD for RFA. He had history of recurrent palpitation. This is the sinus rhythm ECG. You can see here, V1 negative, V2 negative, 2-3 positive. So it is a right-sided pathway, 2-3 positive. So it is axillary pathway, and it is anteroseptal pathway. If 2-3 that is the postseptal. As 2-3 positive, it is anteroseptal pathway. And mapping in the accessory pathway, we found that this pathway is close to the AV node, this is anteroseptal location. So we can see here, this is a catheter. This is his catheter, the AV node, and this is the ablation catheter. This is found close to the AV node. That is here. This AV node is here. This anteroseptal location is here. So mapping catheter is here. So we found this pathway is location in the pathway. As the patient has recurrent palpitation, and so this is high risk of AV block. So I ablate this tachycardia and with low watt, gradually low watt, high watt. And you can see here, there is a his electrogram in the ablation catheter, and there is no delta wave in the ECG. The patient is doing well. And after ablation, there is no delta wave. Patient is sinus rhythm. This is another pathway, accessory pathway, that is antiseptal pathway. This patient has a high risk of AV block, so we did not ablate, because left side you can see here there is a AV close to the AV, and when bumping the catheter, that is the clean cut is, so we did not avoid the ablation because of high risk of development of complete heart block. Thank you very much for patient hearing.
Thank you, Dr. Mohsin Hossain, Professor Mohsin Hossain, for your brilliant presentation. You have shown us how to detect the pre-excitation of WPW syndrome, WPW pattern, and also have shown many cases. Professor Mohsin sir, can you stop sharing your screen? Thank you. Thank you very much. We have got some question for you, Professor Mohsin Hossain. One of the question is, in LGL syndrome, we found atriohesian pathway. How we identify?
LGL is so-called, it is called mainly, now it is called enhanced avineural conduction. But adhesion pathway, mainly connection to the atrium to the his. Adhesion pathway is produced looks like mainly, sometimes it acts as a bystander. It does not produce any tachycardia, or sometimes it's produced looks like AV node ADN tachycardia. By EP study, for the last 15 years, I don't get any this kind of external pathway. So by theoretically, I can say this. It can produce narrow complex tachycardia, looks like AV node, or it's actually bystander tachycardia. That's up. Any comments, sir?
Dr. Mohsin, can I ask you a question?
Yes, sir.
As it is between the AV node and the Hessian, any drug that attack on the AV node, can it be able to control this arrhythmia?
Yes, this is the drug that block the AV node, beta blocker and verapamil, miltiazine, digoxin.
So these drugs are very likely to be effective in this condition.
Yes.
Thank you. We have got another question from Buddhadev Ganguly. How we identify MIME fiber tachycardia in ECG?
MIME fiber tachycardia in ECG is very difficult. Sometimes patient in ECG there is a minimal pre-excitation because it is atria to the right bundle. Connection from the atria to the right bundle. As this fiber conduction property is the slowly conduct, so it looks like AV node. So the minimal pre-excitation or no pre-excitation. So 12-bill ECG is very difficult to identify. If there is minimal pre-excitation, you can guess there could be MIME fiber tachycardia. If the patient got tachycardia, wide complex tachycardia, because all MIME fiber tachycardia they produce the wide complex tachycardia, that is, and left bundle morphology, left axis deviation. We can guess there, but it should be confirmed by EP study.
So
Thank
from
you.
ECG, we cannot actually identify it.
If the minimal pre-excitation, then you can say it could be MIME fiber. Most of the time, it is normal ECG.
Sir, Rafiq sir, comment
sir.
about it.
So the same problem, and if the patient presents with tachycardia, we think SVT with left bundle morphology, and there is minimal pre-excitation, we can only suspect. Because remember, minimal pre-excitation we can also see in patients with WPW syndrome. So EP study is the one when we can really confirm this pathway. It's kind of interesting pathway because it is like a second AV node, because normal accessory pathway has no decremental property, it's all or none. But the MAHIME behaves like another AV node somewhere on the right side of the heart. And once you diagnose it and you find the ablation, is very simple procedure.
One thing, sir, Rafiq sir, we read during our fellowship that the MAHIME causes normal peer interval with pre-excitation.
Yeah, because absolutely right. But you will not see that typical, because you see that, as I told you, this looks like it behaves like a second AV node.
Yes, sir.
So that's why the phenomena happens, that there is slowness of conduction in that pathway, and then there will be some pre-excitation. Absolutely
Yes.
right.
Yes.
Thank you, sir. Rafiq sir, you have mentioned a criteria about the decremental conduction of the pathways. For our fellows, can you explain it, please?
I'll leave it. I think Mohsin, I'll ask Mohsin to wait, and then I can.
Yes,
The
Mohsin.
means the AV node conduction. You can see the AV node when the pathway starts from the sinus node, goes to the AV node at the PI interval, because the conduction slow in the AV node. So it becomes slow when cross the AV node, but it bundle then faster. So this is the called decremental conduction. It's slow in the AV node. This is conduction property. So it is the slowness or decremental property in the AV node. And this
Initially fast, then slow, then very fast.
Very, very fast. This property is found in the MAHIME fiber. Also, this property can find in the EGRT. That is the retrograde conceal pathway. Children produce incident tachycardia. This is also the decremental conduction. So this produces the slow tachycardia at 120 rate most likely. So narrow complex tachycardia produces cardiac. So it is also slowly conducting accessory pathway.
That means PGRT will look like a sinus tachycardia, but without any variation, any respiratory variation. As Sir was previously said, any tachycardia that it looks like sinus tachycardia, but without any variation, suspect that it could be PGRT.
Let me make a comment on this. Decremental and non-decremental. What it means that if I drive a car from Dhaka to Mymensingh on a holiday, I can go as fast as I can, and nobody will stop me. That's the non-decremental conduction. On the other hand, I live with Uttarai and I go into Tongi and I got into this traffic jam because there are many people. I can drive fast, but I'll slow down because of the traffic jam. That's the AV node. So, and what AV node does, the faster you travel, the longer it will take. And that means the AV node has this decremental property, and it is designed to protect the heart, because in conditions like atrial fibrillation, the ventricle doesn't want to conduct fast, beat fast. The AV node protects it. During atrial flutter, we get 2-to-1 conduction. That is because of the decremental property. But the accessory pathway can conduct as fast as it can. That's why when patients with atrial fibrillation WPW syndrome develop atrial fibrillation, the ventricle can beat very fast, like 300, 400 beats per minute. I have seen patients with 300 beats per minute because they don't have decremental. But now saying that, there are some accessory pathways which have decremental property, some degree of decremental, but majority of them have no decremental. That means they can conduct as fast as you want them to. Thank you.
Thank you, sir. A question from Krishna C. Odhikari. Can we rule out orthodromic AVRT when RP interval is less than 70 millisecond?
Thank you.
Sir.
Yes, short RP you can guess, but mainly you can see the POF. If the POF in the ST segment and TOF morphology is distorted, so we can guess this is the accessory pathway. Otherwise, it's very difficult to say.
Very difficult.
I'll make a comment on this.
Sure, sir.
All the criteria that we use are correct 80 to 90% of the time. Please remember that you can fit any of those criteria in any arrhythmia. So what we mean by when the retrograde P wave is within 70 milliseconds of the QRS complex, our first diagnosis is AV node reentry. But it can also be an orthodromic atrioventricular reentry because there's an accessory pathway very close to the AV node. Like the patient that Mohsin showed, his accessory pathway, that pathway is going to conduct, the retrograde conduction will be very close to the AV node. So that formula will not apply. So please remember, any criteria in ECG that we use, they have their sensitivity, specificity, and differential diagnosis. Thank you. Jalal sir, assalamu alaikum.
Sir Mohammad Jalaluddin sir.
Yes. Sir is always here. We have specifically invited Sir. He likes to present. We like him to be present here.
One thing I'd like to hear from Mohsin Hussain, that in atrial fibrillation, when there is many a time we find in our hospital the atrial fibrillation in emergency department, and when we get atrial fibrillation, first of all we start the amiodarone. If it is atrial fibrillation with accessory pathway, whether this drug, the amiodarone, will do any harm or not. Will you answer this thing?
Yes, sir. Because the amiodarone we can use, but there is some reports there, it can produce BF. So it is better to avoid amiodarone, and cardioversion is a choice of treatment, sir.
Sir, best drug for WPW syndrome with AFib is procainamide. Unfortunately, drug is not available because it is not used as much. So even in America, we can't find it anymore. But the VF issue is an issue. But what happens if you are in a facility where there is no cardioversion possibility? You are in a small hospital, you cannot do cardioversion. What are you going to do in that situation? I think you will have no choice than to start amiodarone and keep the patient under observation. It is not always true that they will develop ventricular fibrillation. It may develop.
Sir, I want to.
Sir, yes.
Sir, I want to discuss. Sir, this is a big problem in our clinical practice. This group of the patients, sir, until they undergo the ablation during this period, interim period, if the patient is very much symptomatic, what medicine we can prescribe, sir? This group of the patient who has presented with the atrial fibrillation with the WPW syndrome, is there any drug, sir?
Best drug is class 1C drug. Flecainide is very good. And if you do not, flecainide is wonderful for WPW syndrome and it blocks the pathway. But if you don't have flecainide in Bangladesh, you can try to use propafenone. We don't have much experience with propafenone, but we have a lot of experience with flecainide. And they do very well. One of the issue of atrial fibrillation with WPW syndrome for the younger doctors. Patients with WPW syndrome are prone to atrial fibrillation. And once the WPW syndrome is fixed, the incidence of atrial fibrillation, they will be either cured or the incidence will be very, very low in this patient. So patients with WPW syndrome and atrial fibrillation per se does not need treatment for the atrial fibrillation itself.
Sir, is there
But
any
in the clinical practice, we use the sotalol and amiodarone. So most of the patient keep before the ablation, we keep on these two drugs, any of the two drugs, sotalol or amiodarone.
These two are available.
It is available. The problem with sotalol is it's like beta blocker.
Yeah.
I mean, because it's a class 3 plus beta blocker. So you run the risk of blocking the AV node, and if they have AFib. Amiodarone, it's a toxic medicine, but I mean, you're right that if you don't have anything else available. But I think one of the things that you should think about, because I know in Bangladesh you have propofenol.
Yes,
and
sir,
you should try to use that because amiodarone has side effects. And please remember that most of the side effects of amiodarone are chronic. However, patient can develop acute thyroiditis, that's one. And the other one that can kill patient, literally will kill your patient, is amiodarone pneumonitis. If patients develop amiodarone pneumonitis, and if one of your patients is unfortunate enough, they will die from that. So we don't use amiodarone for any supraventricular rhythm at all, unless these are elderly patients, 85, 90-year-old patients, and we don't think we should be ablating. In those cases, we use amiodarone. So please be careful. I mean, you have to use it sometimes. Thanks.
Actually, sir, this is the first time somebody suggested that we can use propofenol for this.
But
I have never heard of it.
I have been using this.
Yeah.
And with a very good result. Patient remain well.
I think this is because that's good, Jamil, because you see, in United States, we don't have experience with propofenol. But if you look at the drug, it is exactly like flecainide with only difference is flecainide has anticholinergic action and propofenol has some beta blockade function. That's the only difference. Otherwise, they're the same. So I think you should consider, and the way we gain experience with anything in medicine, that's what I do, that I use a little bit and see what happens to my patients. One of the things, remember, that it is very difficult to poison rats. Do you know why it is? Rats have genetically programmed that if they find any new food, they will not take too much of it. They will eat a little bit of it, come back after 2 days, eat a little bit of it. So they gain experience by eating that food that they're not going to kill them. Same with medicine. What we do, if there's a new medicine, new modality, I don't think we should suddenly jump into it. Use some and see what happens to your patient and use that experience for other patients. And then again, also choose the patient who is the safest group. Let's say I have a 20-year-old patient with normal heart, no other cardiac abnormality. Propofenol is not going to do any harm to that patient, and I can try that. On the other hand, if somebody is 65-year-old with hypertension, diabetes, I'll be careful. So try on the younger patients, see what happens, and you get the experience. Thanks, Jamil, for that, sharing the information.
Sir, one question to you, sir. Hello, sir, Opik, sir.
Yes.
Hello, sir. Sir, this is my question, sir. Actually, sir, we see the atrial fibrillation in a WPW syndrome, particularly the young patients. Sir, my question is, whether the problems are coincidence, that is the atrial fibrillation, this group of young patients, or it is the property of the, or function of the some, that is accessory pathways, sir?
The question is, young patient, WPW syndrome with atrial fibrillation. I think it is due to the presence of accessory pathway. If you look at it, that it is possible that there is some retrograde conduction for the ventricle, and it is stimulating the atrium, and that is acting as a trigger for the AFib. So that's why majority of these patients, once we ablate the WPW syndrome, accessory pathway, AFib goes away. The atrium is fine.
This is also my experience. All the patients who have WPW with AF after ablation, the follow-up, they don't have any atrial fibrillation.
Sir, an interesting question is here. Dr. Hassan Saad has asked, I think we should have very clear idea about it. During management of WPW, as it is a part of supraventricular tachycardia, AVRT, why could not we use adenosine here? Everybody should be aware of why we should not use it. Sir.
Oh, adenosine. No. So it is not true that we cannot use adenosine.
We can use it. But
you see, if somebody comes with narrow QRS tachycardia, I know either it is AV node re-entry going through the AV node and his bundle, or an accessory pathway that is going through the AV node. It will be a problem if it is a wide QRS tachycardia and there is a possibility of AFib, or one of the ECG that motion showed that almost like a polymorphic VT, and you give adenosine to that patient. What will happen? Heart rate is now 200 beats per minute, then it will become 300, 350, and patient will develop ventricular fibrillation. So you're absolutely right. It is not that we cannot use it. We need to be careful about it. That's about it.
And
otherwise,
particularly if a patient has documented history of wide complex tachycardia with WPW, if he presents with narrow complex tachycardia, we should not be using adenosine in that case. Is it, sir?
To be interesting.
We have to be careful because you see, you can then reverse, the pathway can reverse, or maybe patient had atrial fibrillation. There is no data that adenosine produces AFib. I mean, it can cause asystole, but I have not seen atrial fibrillation with adenosine.
Sir, if
Professor Rafiq,
yes, sir.
Usually atrial fibrillation when it's less than 40 years of age, I think all patients should go for EP study. And because below the age of 40, the atrial fibrillation due to the caused by other reasons like complications of hypertension or valvular disease or ischemic heart disease. But below the age of 40, those causes are less. That's why whenever there is atrial fibrillation below the age of 40, all these patients should go for EP study. Is it true?
And why are you saying that, sir?
Because these patients below the age of 40, sometimes it may be, there may be atrial fibrillation followed by VT, and there may be sudden cardiac death.
Well, you know, I always tell Jalal sir is always ahead of time. I mean, this is, we talked about it yesterday. I mean, you bring up questions, you are provocative. I mean, this is what medicine is all about. The question is, if somebody, young people have atrial fibrillation, should we study them? We don't, but we need to keep in our mind, like, is it possible that this patient has concealed accessory pathway that we cannot find? The likelihood of having ventricular arrhythmia will be low if the LV function is normal and there is no chance of ischemia. So we do not study them routinely. It's always something that you should keep in mind. I mean, the bringing up the question brings up the issue that if accessory pathway patients have more atrial fibrillation, is it possible that young patient has atrial fibrillation? And we have actually found very rare cases that we have done a study, and we found that these patients have concealed accessory pathway, and we fixed it, and the atrial fibrillation went away. Thank you,
Can
sir.
I add something,
Thank
sir?
you.
Can I add something, sir? In a youngish patient, if the patient have atrial fibrillation, I would look for the underlying cause. And if the usual underlying causes are not manifested, we don't have any recognizable cause, then it belongs to the group of lone atrial fibrillation, which should not have happened in a younger patient. And in that particular set, I think EP study may be important.
Sir, I have a comment, sir.
Yes, sir. Sir, please.
Sir, what Jalal sir has told, actually, this is a great observation, sir. I can remember one of my experience, one of my young patient presented with, once upon a time he has got the atrial fibrillation and another time narrow QRS tachycardia. I took him into the EP lab and he underwent the EP study, and atrial pacing shows widening of the QRS complex. I think he had the that is the intermittent WPW. Actually, that was not manifested, and I have not seen in ECG. So I think what Zala sir has told is the great observation, sir. Really, I did not think like this. But I think that this may be a combination that a young patient may have sometimes, like what Rofik sir has told, may have the constant pathways or may have the intermittent WPW what we can miss frequently. This is a great observation, I think, sir.
But one thing I should always say, before atrial fibrillation, we should always look for the other causes. If it is not here, then we should think of the accessory pathway is a cause, possible cause.
True.
Exactly.
Firoz,
Exactly.
any question? Any other
Thank
question?
you. Sir, there is a condition in many of the cases we find ECG with pre-excitation like WPW pattern, and patient is going for non-cardiac surgery, and the surgeons are sending the patient for cardiac consultation. Should we take any extra measures, or what should be our advice to this patient or to the surgeon?
বলেন
Dr.
স্যার
Mohsin,
আচ্ছা স্যার বলেন স্যার
this is a common scenario.
Mohsen, answer please.
This patient means if the patient is asymptomatic, no documented tachycardia, no palpitation, so they can do the procedure very well. If the patient has documented tachycardia, WBW with documented tachycardia or atrial fibrillation, narcoleptic tachycardia, it is better to do the ablation and after ablation because they are afraid of tachycardia during procedure. So it is better to ablate if the patient has documented tachycardia. If the patient is asymptomatic, so they can do the procedure easily.
But let's say it's an emergency operation. What precaution we can take?
Let me make a comment about this. The preoperative evaluation of cardiac patient for non-cardiac is very, very important. We have to understand what are the risks. There are two risks. One risk is during anesthesia. I work with anesthesia a lot because of ICD implant. Blood pressure is, let's say, 130. And during induction, blood pressure drops to 70 millimeter of mercury systolic. Okay, what will happen if somebody has 60% LA deletion? This patient is going to have a myocardial infarction, or 70%. So risk of myocardial infarction is the main issue that we need to avoid. Second is risk of heart failure during the procedure. So this patient has EF of 35%, well compensated, goes to the operating room, gives anesthesia, blood pressure drops to 80. They give fluid, 2 liters of fluid, patient goes into heart failure during the procedure and acute pulmonary edema. These can be dangerous to this patient. Somebody goes into SVT, you just give a shock or you give adenosine, they will convert. So that is not a life-threatening condition. They need to be aware of that. So if somebody has any arrhythmia and they need to go for surgery, what we tell the anesthesiologist, look, this patient has SVT or sometimes have VT. Just put a defibrillator pad on the patient. If the patient goes into this arrhythmia, just shove the patient out of it because patient is already under anesthesia. That is the important part. But the two issues for preoperative clearance, risk of myocardial infarction and risk of acute congestive heart failure during surgery. Those are the two issues that can literally kill the patient on the table. SVT will not. Thank you.
Thank you, sir. Question from Shomir Paudal. Do patients with WPW pattern have high risk of developing a atrial fibrillation than the other general population?
I thought we already discussed that. We discussed it already,
okay.
Right?
Okay.
Yes,
sir.
clearly. I mean, patients with WPW syndrome will have higher incidence of atrial fibrillation compared to similar group of patients normally. Let's say if we take patients less than 50-year-old, chance of atrial fibrillation is very, very low. And if similar group of patients have WPW, they will have AFib. And the treatment is take care of that accessory pathway, and that will take care of the AFib. Thank you.
Thank you, sir. Some tricky question from Dr. Sudhir Shah. What will be the ECG in a patient of WPW with first-degree heart block, where PR should be prolonged?
I had one patient that this patient, I ablated the pathway and the patient developed complete heart block. So what was happening in that patient? That he actually had congenital complete heart block and was conducting only through the accessory pathway. So that ablation, what I did, I gave a little burn and it went into, I stopped the ablation, conduction came back. So his connection was actually the AV node. The first degree AV block will not be manifested in that patient. It will conduct through the accessory pathway unless the patient has MAM fiber or very poorly conducting accessory pathway, otherwise the PR will be short.
Sir, I want to ask one thing regarding this. I ablated one lady with the first burn of 5 to 8 seconds. The accessory pathway gone off. It was on the left free wall pathway. But after the delta wave disappeared, she developed transient complete heart block. It persisted for half a minute, then it came back. What may be the reason, sir?
So the question is transient heart block. I mean, it's tough to explain. One possibility is that, let's say, the patient has left dominant coronary artery, and the AV node artery was coming from the circumflex, and there was spasm of the coronary artery. That is one possibility. Vagal tone, high vagal tone we see in AFib ablation, that is unlikely to cause complete heart block. It can cause, that will be the only explanation of this happening. It is a remote possibility, but it can happen.
Thank you, sir.
Dr. Birat's question.
Sir, another question of Dr. Sudhir. How to differentiate WPW with posterior septal accessory pathway from inferior MI in ECG? A patient with WPW with negative in the 2-3 AVF and develop inferior MI. How to differentiate?
Because
Dr.
the
Moshin,
patient,
sir?
the patient has that is the short pair interval, delta wave, pseudofusion, and you have in these pseudo infections. So it is a clinical delta wave present there. This we can short pair delta wave.
The problem is the patient has pre-existing WPW that mimics inferior MI, now actually had inferior MI. How
exactly.
you are going to differentiate it?
By ECG we can differentiate. There's a short pair interval and there's a delta wave, and this is the main part of the differentiating from the ECG.
Can I say something? The diagnosis of ST elevated MI actually depends upon rise of the biomarker along with one of the any three. One is classical symptom, second is the ECG changes, third is echo changes, or if I go for cath, etc. So actually the clinical scenario will help us to determine whether the patient is actually having an MI.
In fact, the problem is whether a patient has got inferior MI 6 months back. He has got also WPW syndrome. Can we say that these two things are coexisting by reading the ECG?
It would be difficult from surfaces.
Yeah.
As because if it's a posterior septal pathway 2-3 AVF, this has negative QRS complex as well as delta wave. So it would be very difficult to distinguish from pathological QF with this posterior septal, especially the right-sided pathway.
Because, sir, any comments, sir, about this?
Well, if you remember, 2 weeks ago I showed an ECG, which was basically a patient had sinus tachycardia with WPW syndrome. But the first ECG, there was no way you could tell the difference between inferior MI, old inferior MI. So what we report in ECG, suggestive of inferior MI, but then you look at the other lead to see if you see delta wave. Now, if the same patient develops acute inferior microinfarction, you will have a combination of both. That means what will happen when the heart rate slows down in other lead pre-excitation becomes less, and you still have a Q wave, you know that this is really inferior microinfarction, but there will be overlap. There will be confusion. I mean, you can take it to the best scholar in the world. I don't think they will be able to guarantee that this is not WPW syndrome with inferior MI.
Exactly, sir.
In acute myocardial infarction, in acute.
Sir, should we go for next episode, sir? Because there are so many questions.
Okay, thank you.
Sir, Jala sir, do you want to ask any question, sir?
One small question.
Okay, sir.
Or you can say it is common. In case of inferior myocardial infection, many a time we get
first degree heart block or second degree heart block, sometimes the third degree heart block. And we observe these patients. Most of the patients revert to sinus rhythm. But in that case, we don't find any delta wave or short pair interval. But I think this should be properly observed for a few days, and later on, the follow-up should be done whether there occurs any delta wave or the short pair interval in the future. In that case, if it is found, then we can go for the EP study.
Thank you, sir. Thank you. One last question, Professor Mohsin, from Manoj Koirala. Is asking about can we use QRS axis as delta wave axis, or what is the difference between these two? Delta wave axis.
Only a lot of algorithm, most of the algorithm in the delta wave, some use the QRSX. We can use both. But EP study will final the location. But you can guess but it sometimes may not be true. The delta wave or the QRS complex.
Okay, thank you. I think for this we are running out of time, so we should move to the next episode, the episode of our teacher, Dr. Rafiq Ahmed sir. But before going to that part, we have got an announcement for our attendees. In the next Saturday, on the 26th September, there is a session at the same time by Bangladesh chapter of American College of Cardiology and Bangladesh Cardiac Society. So the ECG, our this session will be shifted to Sunday, that is 27th September on the same time. Now, may I request Rafiq Ahmed sir to go with his session, please.
Good afternoon. So we'll do the EKG, same format. I'm going to show ECGs. Please remember, this time I'm going to jump from topic to topic, so there will be a lot of variation. That's what real life is all about. The first ECG is this one, and I have given 4 choices. We have the answer box, right?
Okay. We'll give 30 seconds time for the attendees to give you answers. I think the time is over. So 60% answer is D. 60% answer is D. 21% C. 11% A, and 5% B. Majority is with D.
This is Odud's ECG, right? Odud loves this ECG. But what do you think? That was pretty good, right?
Yes, sir.
So the whole point is that majority said sinus rhythm, right atrial enlargement, right axis deviation, right ventricular hypertrophy. And how many said posterior infarct?
Posterior infarct only is 5%, sir.
5%. Yeah, I mean, so the reason why did they say posterior infarct? Because there is tall R wave in lead V1. The difference between right ventricular hypertrophy and posterior infarct can sometimes be very difficult. Please remember, the sensitivity of right ventricular hypertrophy criteria is very, very low, and specificity. It's like, I was looking at the data, it's about 12 to 20% at best, all the criteria that we use. But posterior infarct, correct me if I'm wrong, if the T wave was upright,
Yes.
V1, V2,
Yes.
that will definitely become a posterior infarct, right? So
Yes, sir.
that's one criteria. So look at this.
Asif, please mute. Asif, please mute. Yeah, sir.
Okay. So right ventricular hypertrophy, differential diagnosis, it can be normal young adult, true posterior infarct. Interestingly, isolated left ventricular hypertrophy can sometimes produce ECG exactly like RVH. WPW syndrome can look like RVH, and COBT patients, because there is rotation of the heart, that can cause this problem. And so the criteria that are used right axis deviation more than 110 degrees plus, RS ratio in V1 more than 1, which is true in this case, R in lead V1 0.7 millivolt, that means 7 small boxes. Here it is 1.1 millivolt, which fulfills that criteria. S in V1 less than 0.2 millivolt, which is very true in this case. Of course, we don't have RSR, and the supporting diagnosis criteria will be T inversion and ST depression in anterior chest lead. So this patient has 1, 2, 3, 4, 5 of these criteria fulfilled. So this is right. And then, of course, please don't ignore this right atrial enlargement. This R wave, P wave is narrow and more than 2.5 boxes. Thank you.
Sir, please
Yes.
stay with it. Two things I want to say. Number one, the P wave, even sometimes it's the morphology, the sharpness of the P wave in inferior leads. That's much more important than the actual amplitude. Because in COPD patient, you can get lower amplitude. Number two, in case of posterior MI, I always tell my students, look at the T wave. You are not supposed to get beautiful upright T waves in V1, V2. They are supposed to be very humble. If you get a very upright T waves in V1, V2, then look at the R wave. Is the R wave tall? Then it's most likely posterior MI. And it's also supported by if there is ST depression as well. Thank you, sir.
This is good. I think that session is working. So
Yes, sir.
I have this, another one. We have 4 choices. And you can see the ECG clear. There is some baseline wandering, but it looks pretty good. ECG.
So we have got 30 seconds of that, sir.
Okay.
63% says it is D, 26% C, and 7% B.
Good.
Very good, sir.
Yeah. Actually, B and C, I put the same diagnosis. Yes. So that's fantastic. So that's very good. So I think we are. So it's what are the criteria? Please remember the criteria. I mean, there are many different criteria that are used. I'm sure what you did in this case, you look at the R in V5, which is 1, 2, 3.2, 2.8 millivolt here, and then 1 millivolt, 3.8 millivolt. So a voltage criteria, S in V1, R in V5, more than 3.5 millivolt is our left ventricular hypertrophy. And then, of course, there is ST wave changes. Please remember this T wave change. It is asymmetric. If you look at this slope, and this slope is different, asymmetric T wave inversion is suggestive of hypertrophy. Ischemia have more symmetrical T inversion. And then left atrial enlargement, you did not forget that, so that's great. Thank you. And then please remember that sometimes the ECG machine will give diagnosis. Sometimes I say, well, is it making a mistake? They use lot of different criteria. They will look at the limb leads. They will look at the R in AVL more than 1.1, R in lead 1, S in 3, more than 2.5. Those criteria also are used for. I mean, these are all for academic interest because nowadays we have echocardiogram. So echo tells us if there is LVH or not.
Sir, one question, sir. Hello, sir.
Yeah.
The
Yeah.
previous is, sir. Sir, actually, we have got a practice to differentiate the, sometimes in case of the LVH, there is a question whether it is the pressure overload or volume overload. Is there any scope, sir, to discuss such issue, that is the pressure versus volume?
Oh, good.
There is some also written in some books, sir, like.
Actually, if you, along with the LVH and the LA enlargement, if you get the T wave that's upright instead of the strain pattern, that suggests that you are going to have a volume overload pattern.
Exactly.
Thank you.
Sir, what is the sensitivity and specificity of these ECG criteria?
I'm not sure, but
Oh,
not
no.
much.
Exactly.
Not much.
This is interesting. This is better than RVH, but it's about 49 to 50%.
Yes, not much.
It's amazing that it is how low it is. Also remember that we use 3.5 millivolt, right? That's the
Yes, sir.
criteria developed by the Western countries. In Japan, it is 4.5 millivolt, and Bangladesh, I think it will be 4. Because American or the European people are big people, so their ECG is lower voltage than in. So the Japanese have studied it. In Japan, they use the criteria S in V1 plus R in V5 more than 4.5 millivolt. So this one.
Can you show the poll box? So it's 30 seconds. Sir, 87% says it is D, 13% C, and 2% A.
Yes. Question is, how did this 87% come up with LVH? So that is important because commonly used easiest formula is S in V1. And S in V1 in this case is 1 millivolt, and in V5 is 1.8. So S in V1, R in V5 is not fulfilling the criteria. So I'm very happy. I'm sure the participants used the limb leads in this. So let's look at it. The criteria that again in limb lead R in V1, S in V3, lead 3. I'm sorry, R in lead 1, S in lead 3, more than 2.5 millivolt.
Yeah.
In this case, it is 1.4 and then 1.8 millivolt. Plus here is 1, 2.8, almost 3 point something millivolt. And that limb lead criteria fulfilled for the LVH. So definitely left ventricular hypertrophy is there. We don't have that ST. There is some ST segment change, and then evidence of left atrial enlargement. So that's perfect. Thank you.
This also suggests the upright TF suggests this could be volume overload, sir.
Oh, good. That's it.
Good.
Maybe hypertension.
All right. This one. Let's put the time.
Yes, sir. Timer is on. It's 30 seconds, sir. 63% says it's D, 21% C, and 16% B.
Okay. So that's pretty. I think that. What do you think? Well, that's a pretty good answer, right? I mean,
স্যার তার সাথে ফার্স্ট একটি হার্ট ব্লক আছে স্যার
the PR interval actually is, if you look here, it's 200 millisecond. I measured it.
আচ্ছা
I did not give it, so I measured that. If you move this out, it's almost 200, 210 milliseconds, or maybe 220. It can be a little bit of further. So, I mean, so sinus tachycardia is correct. Heart rate is 108. There is a elevation in lead 2. There is, of course, some baseline on lead 3. AVF, I'm not so sure, maybe some. I'm not making any comment about ischemia or anything, unless Wadud wants to make. There is left atrial enlargement, and of course, LVH by which criteria? Let's see. So if we go in this patient, lead AVL is about 1.1 that fulfills the left ventricular hypertrophy criteria. Lead V5, we have 1.4 millivolt R wave, then 1, 2, so 3.4. So V1 and V5 fulfill the criteria, voltage criteria for left ventricular hypertrophy. Thank you, that's pretty good.
And another is, sir, if you get a taller, usually in normal ECG, the tallest R wave is in V5, which is more than V6. If you get a taller QRS complex than V5, then that's a possibility that there could be LVH. You have mentioned that.
Yes. So this one, survey please.
The 30 seconds is over.
Okay.
41% says it's D, and 38% says it's B. 25% C.
That's interesting. So 38% atrial fibrillation. So, okay.
Yes.
Let's start with atrial. Is it atrial fibrillation? If you suddenly look at it, it looks like there is a pattern there. It is not irregularly irregular. So it's not irregular, but it is not irregularly. It looks like 2 beat, a gap, 2 beat, a gap, 2 beat, a gap. And if that's the case, it cannot be atrial fibrillation. So I will totally disagree with atrial fibrillation diagnosis. So what are the other?
Second one is 4.
Number 4.
Sinus rhythm with Wenckebach.
How many percentage? Firoz, how many percentage atrial
38% says it's atrial fibrillation and 38% says it's 4. Sinus.
How about number 3?
Number 3 is 25%. 25%.
So number 3, 25% sinus rhythm with Wenckebach block. Perfect. And then numbers. So let's look at what we have here. So what we have here is, I have marked the P waves. In lead V1, this is the rhythm strip. These are the P wave. See, there is a P. PR interval is 240 milliseconds. Next PR is 320. Next P wave is not conducted. And next P wave is 240. One of the tricks to look at is after the block, the first PR interval should be short. That is very much pathognomonic of or diagnostic of Wenckebach AV block. So that is true. But we also should not ignore the T wave. Look at the T wave. In lead V1 and V2, you can embed V3, V4, V5, V6. And Firoz, any comment on this T wave inversion? What do you think of this?
Sir, this is symmetrical T wave inversion extending from V1 to V6 and also in 1 and AVL. It may be due to entry wall ischemia.
Yes. So that's the part. Please remember that if it is a symmetric T inversion, we need to keep in mind ischemia. I will not say acute MI or anything. Consider ischemia. If this patient is having ongoing chest pain, that's one clinical scenario. Please do not ignore the patient's symptom. If the patient is having symptom, it is of something that needs to be addressed immediately. If the patient is not having symptom, that's the finding, ECG finding for us. Thank you. So next one, I'm sorry, I gave just a little bit of this. This is V1, lead 3, and V5. And I have few choices.
So 52% says, sir, it is B, 2:1 block. 28% says it's D. And 12% is with C.
Okay. So one thing, it is not sinus bradycardia. Some people say sinus bradycardia also.
Only 8% says.
8%. Yeah. I mean, listen, sure. I mean, probably this is the E wave, right? And so if whoever said sinus bradycardia probably are looking at P wave, QRS complex, T wave, and there is a U wave. The funny thing is that this U wave looks exactly like the P wave. So that makes it unlikely to be a U wave. And even then I can be wrong. So I look at other ECG. Second question is whether I should use the diagnosis of 2-to-1 heart block or Mobius type 2 second degree AV block. I'll leave it to our panelists. What do you think?
Jamil Bhai.
To me, it is 2:1 AV block, sir.
Perfect. I mean, listen, without further information, we cannot say if it is Mobius type 2 or not. I mean, I will just call it 2-to-1 heart block.
Yes, sir.
When we say Mobius 2, that means we are talking about infra his AV block. And that happens if there is no PR prolongation. But I cannot say whether there is any PR prolongation or not before the block in this ECG. So in this ECG, my diagnosis will be 2-to-1 heart block. That's it. আমার যে সারা এসে পিটায়ও আমি তাও ডায়াগনোসিস চেঞ্জ করব না। So look at it. The same patient, same ECG. I just erased part of it. If you look at it, in lead V1, P wave, QRS complex, P wave, no QRS, P wave, QRS, and then P wave with prolonged PR interval. And then probably there is a P wave buried in here. And then once it goes into 2-to-1, we can't see any difference. So this is actually, and now I can tell this is type 1 second degree AV block, but it's becoming 2-to-1. But with that just rhythm strip, we cannot tell that. But even when I say type 1, I'll say Wenkeba followed by 2-to-1 heart block. So the diagnosis will be my ECG diagnosis, sinus rhythm with Wenkeba and followed by 2-to-1 heart block. And mechanism-wise, I can say this is probably the block is in the AV node because of the presence of Wenkeba. But this part of the ECG diagnosis should be 2-to-1 heart block. And that's how I'm going to report it. Now, so that this, the good thing about this patient was this patient has narrow QRS complex. So now let's look at the next one. Next one. This patient has wide QRS. And so please.
So time is over. 59% says it's 2:1 block, and 30% says it's Mobius type 2 second degree AV block, and 11% says Mobius type 1 second degree AV block.
Okay. So again, one is out. With this strip, I cannot say Mobius type 1. Mobius type 1 is you have to see PR prolongation followed by a blocked beat. With this ECG, I have only two choices, either 2-to-1 AV block or Mobius 2 second degree AV block. Again, as we discussed earlier, that Mobius 2 is a mechanistic diagnosis, whether it's infrahis or suprahis block. One of the things people talk about that if the PR interval is normal, it is more likely to be Mobius 2, especially with bundle branch block. But this PR is longer. So I will go for 2-to-1 diagnosis. I'm sure all our panelists will go for the diagnosis of 2-to-1. Is that right?
Yes, sir.
Yeah. So
one thing, sir, Dr. Govindo,
yeah.
I have to say, lead 2, if you consider the RR interval, it's not regular in lead 2. and second and third beat, it's wide than that of previous first and second R wave. So in that case, can you comment Mobius type 2 then rather than 2:1 block? PR interval fixed, but some P is non-conducted after second QRS complex.
Govinda, there is only 2 complex in the ECG. So you cannot calculate regular or irregular RR interval. You need some more longer strip.
Longer.
Yeah. So only 2 in complex.
Three
you cannot
complex.
compare the RR interval. No, RR interval for is only two complexes in every lead. 3 complex. The other
3
lead
complex,
is
2 RR intervals.
No.
Longer
The
rhythm strip
third complex in rhythm is almost equal.
Yeah. So
in 2:1 or complete hard work, there is some irregularities. It is seen.
Exactly. So I think with this, with the wide QRS, if the PR interval is normal, I may have called it Mobius 2. Because as I said, the PR prolongation normally, these are mechanistic diagnoses. So I think better diagnosis for us will be to keep it just 2:1 heart block. And if somebody asks me, where is the block? Where is the location of the block? Is it in the AV node or is it in the his bundle? So let's look at the next ECG. Same patient, same look at this. What's happening? The patient has baseline first degree AV block. And the last PR interval is about 400 milliseconds. Yes. And then there is a block, and then there is still first degree AV block. So basically it goes to 2. Again, this is actually probably the block is in the level of the AV node. And over here, until here, I'm going to call it Wenke-bar. And once I switch to this, I'm going to go. And then look at this also on the last bit also conducting. The Wenke-bar. It's basically diagnosis for that portion will be 2:1 heart block. For the whole ECG, I'll say baseline first degree AV block with Wenke-bar AV block with portion 2:1 heart block. That's it. I'm going to leave it as it is and right bundle bind block.
With also left axis deviation, so that suggests left ventrivesicular block.
Just 1 second. Let me come back. Yes, left ventrivesicular block.
That means the patient will most likely require pacing.
Probably. How about this one? This is rhythm strip, 2 different on the top and the bottom. These are not continuous. These are top one is 1 and then bottom one is a continuation of that.
Sorry, 30 seconds.
Okay.
43% says it's atrial fibrillation with slow ventricular rate, and 37% says it's atrial flutter with slow ventricular response, 17% sinus arrest with junctional escape rates, and 3% as junctional bradycardia.
Okay. So I'll start with junctional bradycardia. Now, junction is irregularly beating rhythm. If I have this bottom strip, I may consider junctional, and I actually measured out the bottom strip. They are regular. And this part can be junctional bradycardia. But the part before is irregularly irregular. First of all, there is no P wave anywhere. I cannot say sinus arrest. Sinus arrest will only, I would say, if there is a sinus beat, and then there is no sinus beat at all, and interval more than multiple. So it cannot be true. Junctional bradycardia, for the whole rhythm, it doesn't apply. Atrial fibrillation versus flutter, even though it looks like fluttery, but it's very much irregular rhythm. So this is atrial fibrillation. And then it becomes regular. Anybody has any comment about this part?
Patient developing complete heart block?
Yes, sir.
Yes.
Atrial fibrillation with complete heart block.
Yes, or high grade. This is for the junior doctors. I mean, where is the proof? We always tell students that, look, if in the setting of atrial fibrillation, the RR interval is regular, that is complete heart block or maybe high grade AV block, right? So they remember the date, 8th of November, 2017. Next day, 9th of November, same year. 2 days later, patient develops sinus rhythm. You see first degree AV block and then becomes high, you see here, 2 to 1 heart block. So this patient has grossly impaired AV conduction. So what we are teaching you that it is high grade AV block is not wrong. So this is another ECG. I'm going to ask the participant to, this will be the last ECG. I hope the answer will be better this time and 100% correct.
Sir, it's 30 seconds. 68% says it's atrial fibrillation. That is number 3 with slow ventricular response. 28% says it's atrial flutter with slow ventricular response.
So that's 100. So nobody said junctional bradycardia or sinus arrest, right?
Yes, sir.
Okay, that's good. At least we have narrowed down. The question is why there is flutter or fibrillation. I mean, even though the wave looks like fluttery, but it's not. It's really a coarse AFib which is recorded. So I think I'm very happy. Although, are you happy with these answers?
Yes, sir.
Yes,
Very
sir.
much.
Perfect. Yes.
But
So
one can argue that it is flutter, but it doesn't actually look like flutter, particularly in the lead 2.
yes. The one thing struck me with this ECG that in the setting of fibrillation, if you look at these 2 intervals, it looks pretty regular. And then I wondered, is there something going on? So this is July 13. 2 days later, this patient converts to sinus rhythm. 15 next day, you see, high grade AV block.
Ah.
So this is interesting that when you find this regular RR interval in the setting of atrial fibrillation, there is underlying, and I have couple of more ECGs. What I do every time I see these ECGs, I go back and try to find ECG follow up or prior to. I mean, this is a coincidence that the patient converted during the hospital stay. We did not cardiovert the patient because the patient was not entered. You see the high grade AV block.
Sir, may,
yeah. Professor Chaudhary, you have to turn your unmute.
Mishkat bhai, unmute karen.
flutter, the previous one, sir.
Yeah.
When we have the previous one, sir.
Yes.
The previous okay.
Yes,
this
yes,
one.
sir. When the patient has got left ventricular hypertrophy and left atrial enlargement, then there is a pet question whether we can detect left atrial enlargement in patient with atrial fibrillation, because in atrial fibrillation P wave is absent. But when there is left ventricular hypertrophy and left atrial enlargement, then if there is appearance of flutter-like fibrillation wave, then this is a feature of left ventricular hypertrophy. And in this ECG, we can see Voltage criteria and ST depression, which fits with left ventricular hypertrophy. So this flutter-like wave that has come into V1 is probably due to left atrial enlargement.
Can I make a comment, sir?
Sure.
It is sometimes said when you have atrial fibrillation, initially it could be coarse, but over time, the fibrillative wave can become very finer.
Yes, yes.
We have been taught like that.
And again, when there is left atrial enlargement, as it occur in mitral stenosis, then again it becomes coarse, and then we know that patient with atrial fibrillation is having left atrial enlargement. That is what actually happening in this patient. We have got the feature of left ventricular hypertrophy. Yes.
Mishkat bhai, even with a very large LA, I have seen very fine atrial fibrillation.
Exactly.
So
Exactly.
it's very
Now
difficult
it is
to say. Compared with the echo finding, LA size 56 millimeter, but the atrial fibrillation is very fine. It's very difficult to discern even fibrillatory wave. It looks like a flat baseline. So it does not correlate with the echo finding, with the coarseness or fineness of the
Yeah.
atrial enlargement.
We used to equate coarse atrial fibrillation with LA enlargement, but nowadays we actually discourage the students from actually equating that.
Yeah.
I'm going to give you a simple.
What Wadud said, the initial, at the beginning of the atrial fibrillation, is usually remain coarse. With time, with prolonged persistent AF, it becomes finer. The fibrillatory waves gets finer, even sometimes difficult to discern the AF waves.
What our experience goes with mitral valve disease, we find atrial fibrillation in a lot of cases, and in a lot of cases we find a coarse atrial fibrillation. That is the reason, because we know these patients are having atrial fibrillation for a long time, and again we can find the coarse wave in the V1, and it is also written in the book. Actually, this is not what I am manufacturing.
Can I is going to make
can I make a comment?
Yes, you
Okay, so let's take একটা ছোট কাঁঠাল নিলাম এবং তার চারদিকে একটা দড়ি বাঁধলাম, and দড়িটার লম্বা হলো 8 ইঞ্চি, and that is the normal sinus rhythm wavelength. এখন যদি একটা বড় কাঁঠাল নিয়ে 1 মণ কাঁঠাল, সেটার চারদিকে দড়ি বাঁধি, সেটা হবে 2 ফুট লম্বা, and that is the left atrial enlargement. এখন সেই বড় কাঁঠালের মধ্যে আমি অনেক ছোট ছোট অনেকগুলো নট দিলাম, multiple knot. Each knot is going to be 2 inches, 3 inches. Those are fibrillatory wave. They will not represent the length of the kathal. And that's what atrial fibrillation is all about. You can make those knots small, big, and you can place all over the surface of the kathal, and that will be exactly like fibrillation. So fibrillatory wave will not tell us anything about the size of the chamber that it is traveling.
Exactly.
Right, sir.
I have a comment, sir. If anybody can comment both atrial fibrillation and flutter, that means both 3 and 4, flutter fibrillation. Give any comments, sir, Rafiq, sir.
Yes, I mean, sometimes we use this term. It's a stupid term. Every time I use it, I said I'm trying to be an escapist because I really don't want to commit myself. It depends. So sometimes you will find this one is a little bit more coarse, more like fibrillation. Sometimes you will find in the beginning, it's fine, and then it gets very organized, almost like flutter wave. Yes, and as a matter of fact, we have done recording. We used to put a catheter in the coronary sinus and record with Holter. And we found that the left atrium is in flutter and the right atrium is in fibrillation. Patient actually had both. So in those cases, we use this term, flutter fibrillation. But this is a little bit more the term that we use, coarse atrial fibrillation. But I mean, if a student, and mechanistically, it is, why is it important to define flutter? Because the flutter is an organized circuit, a single circuit. And fibrillation is not a single circuit. And I think from treatment standpoint, mechanistic standpoint, these are totally different entities. Thank you. I think this is the last ECG. I hope you enjoyed it.
Thank you, sir. No, actually, this term is no more used in the text, Govindo.
Yes, sir. But in case of severe mitral stenosis with mitral regurgitation, some ECG you have seen the flutter-like wave, sawtooth appearance in V1 lead to, and also R wave is irregular. For that reason, I have commented this.
Actually, Govindo, if you get sawtooth appearance of the P wave in the V1 especially, and it looks more regular, then you can label it as atrial flutter with variable AV block, as the RR interval are irregular. But if it is finer and cannot make it a regular interval of the P waves,
some
then it's most likely it is
raise their hands to make comments. Should we allow them, sir?
No, sure.
Hey,
sir,
please.
three participants raised their hands
Okay.
allow
to
karo.
make any question. Rivu, can you allow these three participants?
Yes, sir. Allowing.
Please, participant, make very short, direct comments.
আর স্ক্রিন শেয়ারটা হ্যাঁ
স্ক্রিন শেয়ারটা অফ করে দিই।
Dr. Sudhir Shah,
কই সুধীর
Sir, Assalamualaikum.
an attendee named Tarek and Partho.
হ্যালো
Okay,
সুধীর
Dr. Sudhir, please go on.
Sir, thank you, sir. আমার কিছু কোশ্চেন ছিল, এটা আমি আগের
On your camera.
ক্যামেরা অফ করে রাখছি স্যার, সরি স্যার।
Okay.
আমার আগের ইসের সাথেই কোশ্চেনটা ছিল। আই হ্যাভ কোশ্চেনস, স্যারের ইসের সাথে আমার কোশ্চেন ছিল, কয়েকটা কোশ্চেন ছিল। একটা কোশ্চেন ছিল, আমি গতবারও আমি ইসের মধ্যে চাইছিলাম জানতে, অভিষেক স্যারের ইসের মধ্যে।
Quick, Sudhir, please make short, direct question.
What is the cause of STT changes in case of WPW? And যদি একটা patient, young patient comes up with atrial fibrillation in the CCU with narrow QRS complex, is there any clue just by seeing the ECG to say that the patient could have WPW? If we cannot find any delta wave or any PR shortening, is there any clue or not, sir, in this case? Because it's been said.
Thank you, Dr. Sudhir. I think we have got the question. Rafiq sir, do you want to go for
So
the
the
answers?
question was, during atrial fibrillation, there is no pre-excitation, right?
Okay. Yes, sir. By narrow complexes in atrial fibrillation, can we say that is there any accessory pathway or not?
It is very, very unlikely that if during atrial fibrillation there is no pre-excitation, that there is WPW. But only possibility is that if you get a fib and the refractory period of the accessory pathway is long refractory, it is possible that it is not conducting, but it is very, very unlikely, because most of the time refractory period of accessory pathway is shorter than AV node, and they conduct faster. In extremely rare situation, you can meet a situation whereby there is poorly conducting accessory pathway, there is no pre-excitation during atrial fibrillation.
And the second question was, what is the mechanism of STT changes in WPW syndrome?
স্যার আমি স্যার যদি এইখানে একটু যদি বলতে দেন স্যার, 10 সেকেন্ড।
বলো।
ওকে স্যার, সো আমি একটা রেফারেন্স দিয়ে আপনাকে স্যার বইয়ের নাম বলি, গোল্ডম্যান সিসিজি, and there it has been said that AV node acts as the traffic police between the atria and the ventricles, and it will not usually permit rate more than 180, or you say 200. So if you are getting a rate over 200 or 210, so there is every possibility that the patient could have an accessory pathway, and this is a clue, clinical clue, just by seeing ECG, and my reference is Goldman's ECG, sir. So how right I am, sir?
Well, listen, there are a few things. One, reading books and quoting from the book is one thing. If you look at my ECGs, I don't show any ECG from books. It's very good for my learning. AV node can conduct, most of the time it will conduct up to 180 or so, but it can conduct much faster. We have patients with AV node reentrant tachycardia with in excess of 240 beats per minute. I have seen those. A flutter with 1-to-1 conduction can go up to 250, 300 in rare cases. And I had actually had an 80-year-old person who should not have that, but 1-to-1. So it is not always true that AV node cannot conduct that fast. AV node can conduct fast under certain circumstances.
Vivu, can we go for the next participant?
And STT changes. Exact question.
Yes, sir. A participant named Partho.
Sir.
And
Dr. Partho? Yes.
Hello, sir. Sir, একটা পেশেন্টের কি atrial fibrillation and complete heart block একসাথে থাকতে পারে কিনা, আর যদি থাকে স্যার আমি কিভাবে ডায়াগনোস করব?
কি করছে
স্যার
ওর কথা হলো যে atrial fibrillation diagnostic criteria আমরা বলি irregular QRS complexes. In that case, How can we say that this patient has AFib and complete heart bleed? Sometimes it seems contradictory. That's what he is asking.
Yes, sir. Yes.
Actually, when complete heart block develops, the RR interval becomes regular. As
Partho,
because
can I say something?
Yes, sir. Yes, sir. Yes, sir.
Basically,
Sir.
atrial fibrillation, the QRS count is irregular. You
Hmm.
look at the ECG, you have bradycardic vertebra, it is very regular, but there is no P wave, and the baseline is disturbed by fibrillatory wave. The fibrillatory wave puts the diagnosis in atrial fibrillation, but why the patient is having regular complexes, that put the diagnosis into complete heart block. You have to
and
suspect that.
ventricular rate would be lower.
Yeah.
আচ্ছা ফিরোজ
Thank you. Sir.
আচ্ছা আমার মনে হয় সুধীর ইজ নট হ্যাপি আই থিঙ্ক
সুধীরের একটা কোয়েশ্চেন খুব ইম্পর্টেন্ট, why there is
STTG.
ST2
What is the
changes?
mechanism of
you are
STT changes
another question
in WPW?
Mosi, do you want to put in something? Why there is ST2 wave changes in accessory pathways, WPW particularly?
Mainly, this is the accessory pathway. Mainly, one is the conduct to the AV node, and to the one is conduct to the accessory pathway. Initial part is the fusion beat, so it's fused to the sinus beat and the accessory pathway. So it depolarizes the ventricle. So I think this may cause the ST wave.
No, the ST2 wave changes.
Inversion.
That's the QRS change. Why the ST2 wave change?
Asymmetrical T inversion.
Well, you see, the WPW syndrome, a conduction through the ventricle is exactly like a ventricular premature beat.
Exactly.
So let's say there is a PVC coming from left lateral part of the left ventricle near the coronary sinus. And if the 100% conduction happens through the accessory pathway, it will be exactly like the PVC. And it comes to depolarization changes, ST2 wave changes. One of the important things that happens, that change stays in the memory of it's kind of funny, nobody has explained it, that when you ablate WPW syndrome, there is some memory left of that change. We don't know how. And for a few months, you can find T wave changes. Initially, we used to think this is a schema, but it's not. It's just a memory of that old change, and then it disappears. So that's why these STT changes happen with the WPW syndrome.
Thank you, sir.
Thank you, sir.
Sir, actually sir, it means that the depolarization and repolarization goes in opposite direction, sir.
Yes. Dr. Muskie has remained very quiet.
Is there any participant who raised hand? Ribu?
আমার মনে হয় যে
No, sir.
ফিরোজ
No more, sir. So we can go for the next part of the session, ECG of the week.
আচ্ছা
Professor Atta,
Now
sir.
before that, are there other young doctors from Nepal joining us? Or
yes sir
Yes,
nearly
sir. Many
15
questions
doctors,
were from there, sir.
nearly
Oh,
Dr.
15 doctors.
Biraj, Dr. Monoz, all of them actually from Nepal.
fantastic.
There may be a couple of doctors in Facebook too.
Fantastic.
Right.
You know, I'm very happy. I mean, I think this kind of
Acha,
collaboration
Ribu.
is very, very important.
Yes, sir. Yes, sir.
আচ্ছা তুমি ওই ইসিজি শো করো
Sir, thanks to
Yes, sir. That's
Arun Maski, sir, my friend. He is the key person for this
Sir, I'm
collaboration.
starting to share the screen.
There are 89 participants, 89 attendee.
স্যার না দিস ইসিজি রুবিক স্যার
Yes.
Sir, this is the ECG actually open for discussion for
Honorable,
all
please,
faculties. And I
please-
think Rofik sir will be the last person to discuss this ECG. And our Professor Mohsen are already given answer to this ECG. I invite other faculties to take to make some comments about this ECG, sir. You will be the last person, sir, to discuss this ECG. Actually,
Can I keep the background about this? This patient, আমি কি বর্ণনা দিব?
Sure. Yeah.
This patient is a post-CABG patient, had a CABG 11 years back, now has ICM, ejection fraction around 27%. He presented with this in the ER, and his electrolyte was, serum potassium was 2.9, his magnesium was 1.5. Other things were quite all right, and let's discuss.
So I think Firoz,
Sir.
you are the moderator as well as the faculty. So just a comment.
Sir, started with me. It said white complex tachycardia.
Regular or irregular?
It looks
Regular.
difficult to say. Irregular.
Regular.
Most likely irregular due to
Most likely irregular. Irregular.
capillary confusion.
And in B1, there are some irregular complexes. It looks like polymorphic VT.
Polymorphic VT. Arun Maski or our Nepali friend electrophysiologist?
Well, this is a white complex tachycardia, and if the patient has a background of bypass surgery, you should take this as a ventricular tachycardia until and unless prove otherwise, though the complex are different. So to tell this is a ventricular tachycardia, the complex are quite different and it's not regular. So that goes against ventricular tachycardia. And another possibility would be SVT with average is another differential diagnosis.
Why the complexes are slightly irregular? In VT, it should be regular.
Yeah, VT should be regular. So it could be either SPT with average is the likely diagnosis. And sometimes in the patients with antidromic AVRT, this complexes are, the patterns are different like this. So all threes are common, but in the context of a clinical scenario, you should treat these patients as VT, and I would go for VT, though the complex are different because this patient has a bypass surgery and his ejection fraction should be less. And I'm not very able to see the ECG completely here. Well, I'm looking for some, whether I can find some capsule bits or fusion bits, if I can find that.
So Adul bhai.
Yes. Sir,
one last someone actually answered that. Yes, Dr. Inayat.
One of the possibility was atrial fibrillation with bundle bus block, but there is predominantly negative complexes in chest lead. AVR is positive. All these things goes in favor of VT with, I think, polymorphic VT.
Can I say anything, sir?
Yes, sir.
To me, it seems like AVRT with atrial fibrillation. Antidromic AVRT with atrial fibrillation.
I think, Wadu bhai, we will just discuss our interpretation. Then Rofik sir will make the final comment.
Actually, I treat it as VT, given DC shock. And can we have the normal ECG?
No, don't go to the normal now.
Okay, sir.
Can I comment, sir? Pre-excited AF, you can comment here.
Yes, this is also ADD.
Thank you, sir.
Rafik sir, comment করবেন?
Can you see my pointer? No.
No,
okay.
Sir.
No, sir.
First of all, if you look in the bottom strip, that's a rhythm strip. I think it's lead 2. And the morphology all looking down.
Yes.
So that takes away polymorphic VT. The clinical scenario, hypokalemia, I don't think has anything to do with this arrhythmia because hypokalemia can cause VF, not VT. So, and if we look at the chest lead, V1 through V6, it is negative. And that points towards VT. If you look at lead 1 over here, the 1, 2, 3, 4, 5, first 6 beats, regular, similar width. It is similar width that will take away WPW syndrome with AF. Because if it was WPW syndrome with AF, there will be a degree of irregularity in this QRS complex. What puzzles me, 1, 2, 3, 4, 5, 6, 7 bit is narrow QRS. And I thought that was fusion bit. Now, if that was fusion bit, it is complicated by the fact that if you look at lead V1, the so-called VT bit are looking down, but there are positive complexes. And that does not fit with the perfusion bit. One of the possibility is that this is a scar-related ventricular tachycardia. If you think about a scar, the scar can have two different type of exit. So the main channel is one, and there can be different exit, and that can change the cycle length of the tachycardia. So actually, I have the advantage because I looked at this ECG and I showed it to a bunch of my partners, and nobody had any definite answer. But the final diagnosis, we thought that this is ventricular tachycardia, and the reason for irregularity that has been well described in VT is that the main circuit is same, but the exit point can be different, and that can change the morphology and the timing of the complex. So I think that clearly the diagnosis in this case is ventricular tachycardia. Mechanistically, it will be very hard to describe the irregularity. Is it possible to get PVC during ventricular tachycardia? Theoretically, it is possible. If you have a parasystolic focus, which is protected from outside, it can beat on its own. But that is very unlikely in this kind of fast tachycardia. So our thinking was it was a scar-related VT with multiple exits causing this change in morphology of the QRS complex.
Sir, can I add something?
Yes.
The negative complexes in chest leads, there is a notch in the QS complex. Does it suggest there is a scar which goes again in favor of VT? And again, you are saying the different exit. That could be the possibility. That also strengthen your assumption.
Definitely. Definitely.
But that scar should be the sinus rhythm, Madhur bhai. That should be the sinus rhythm, not in the VT.
No, the sinus rhythm. We are not talking. We are talking about the ventricular depolarization waves, because the depolarization is involving a scar. There may be some manifestation in there. We are not talking about ST segment or other things, which we can only decide about when the patient is in sinus rhythm.
Exactly. Sir, one question to you, sir. Sir, with this morphology of the V1, there is a slight, that is the R wave. Can we call it the negative concordance, fully negative concordance according to the Brugada criteria?
Almost. You know, I think all of them are looking down, almost except V1. V1, tiny bit of positivity kind of.
Also V2.
V2, no. V2 is actually negative. If you look at lead V2, it's negative. From V2 onward.
This one, sir?
No, there's a couple of bits, but the main rhythm, if you look at the main rhythm, is actually negative. There are some fusion or whatever bit we are thinking, there is a positive, but the main rhythm in V2 to V6 are negative, except lead V1. I thought you were right. I mean, it's almost concordant.
While I see this is my patient actually. When I see this ECG, I think this is so interesting. I have to show it to everybody.
Sir, V1 also strikes me, sir, the V1. Sir, is there any possibilities of flutter, sir? The V1, sir, just look at the V1.
You're talking about atrial flutter? Well, yeah, I mean, it's possible, but you know, it's such a fast ray that, you know, it looks like flutterage, but it'll be tough to call it atrial flutter. Because if it was atrial flutter, then you have to conform into some kind of aberration, right or left bundle aberration. It does not fit into that.
Yes.
Especially with all negative complex from V2 to V6. Yeah, exactly. So atrial flutter is not the cause of this rhythm. It's not the driver.
Sir, what is the explanation of slight irregularity? Sir, this is VT, sir, true. This is VT, but how we can explain the slight irregularity of the rhythm?
That's what I say.
At the bottom step, could it be due to fusion bit, only the rhythm step in the bottom?
Yes, it can be fusion, number one. Number two, as I told you, that the scar circuit, the common pathway is same, the slow part, but the exit point is different.
Multiple exit.
The multiple exit circuit, and that can change the morphology and the cycle length.
Cycle length, it cause irregularity.
Thanks, sir. Yeah. One of our Nepali colleague also commented like this, sir, multiple exit point.
Yes, definitely.
This
That there is a terminology called pleomorphic VT. Is it like this?
I don't know. I'm not a big fan of different fancy terms. You know, I remember that when we were students, our SARS used to use that. I think these terms are good, but we have to also look at the mechanism. Yes, there is actually a term called pleomorphic ventricular tachycardia.
Josephson first described this one, sir.
Yes. But I think since that time we have come a long way. Now the SCAR, because when Josephson described, and then Bill Stevenson came up with the SCAR and the circuit part. And I think that better understanding now.
Sir,
that gives better explanation.
Sir, the last part, that is again back to Wadud Bhai's question, that is the V5, V6, that is the nose. Sir, whether it is due to the gross widening or because of the scar, what should be the better explanation, sir?
Well, I mean, every time you see a fractionated electrogram, you think of scar. Yes. And I think that's what causes the notching. And you can see, even when you record intracardiac electrogram, you can see those fractionated electrogram, intracardiac channels. So, I mean, it is suggestive of scar.
Right.
I mean,
can I call, sir, fragmented QRS?
Exactly.
This term is
sure. Yes.
Fragmented QRS.
That's it. That's why we are calling it SCAR. Can you go to the answer?
Let's see the normal ECG first.
Ribhu.
Ribhu, normal ECG টা দাও নাই?
Sir.
Please show the normal ECG.
আতা ভাই আপনার কাছে আছে normal ECG টা?
আচ্ছা।
Can you show it?
আচ্ছা, রিবুর কাছে নাই না? আচ্ছা দাও।
না স্যার, এটা তো
আমাকে নরমালটা দেন নাই স্যার।
আচ্ছা না।
তোমার কাছে বোধহয় দেই।
Sir, will I stop sharing the screen?
Yeah, stop.
Yes.
No. Atta bhai, Atta bhai, can you show it?
I've seen the fact that there is entry-MI, old entry-MI.
Yeah.
Yes.
Ribu.
Yes, sir.
You in the V4 to V6 are in the queue in sinus.
This is very interesting, actually.
Ribu, please stop your
Okay,
sharing.
sir, I'm stopping sharing the screen.
Yeah, let Atar bhai show the ECG.
Yes, sir, I've stopped.
Meanwhile, the patient, after one DC shock, converted to sinus rhythm. There was a big Q where we'll find out. And we have advised him to have we put him on amiodarone and have advised him to have an ICD.
What was his ejection fraction?
Around 27. He had bypassed 11 years ago.
How common is this SVT with aberrancy in patients with structural heart disease and low ejection fraction?
জামিল, আমার ECG দেখতে পাও?
না,
Not yet, sir. দেখা যাচ্ছে না, স্যার।
আপনি শেয়ার করুন। আপনি স্ক্রিন শেয়ার করেন আগে।
শেয়ার করছি।
ভাই,
হ্যাঁ?
গ্রিন বাটনটা ক্লিক করেন, শেয়ার স্ক্রিন।
হ্যাঁ,
তারপরে আপনি আগে করেন, আগে শেয়ার স্ক্রিনে দিয়ে তারপরে আপনার ওইটার মধ্যে ইসিটার মধ্যে দেন।
আগে শেয়ার স্ক্রিন ক্লিক করেন আতা ভাই।
হ্যাঁ, করছি। দাও।
এখনো আসে নাই স্যার।
নিচে একটা শেয়ার বাটন আছে না স্যার?
না,
গ্রিন কালার। না, বটম প্যানেল।
না, তার ঠিক আছে, এখানে একটু সমস্যা হচ্ছে। দাও। আচ্ছা, আমার মনে হয়।
আচ্ছা, can anybody see this?
Yes.
We can see. That's a good idea.
Can you make it speaker view, and then what would you speak? Then we'll be able to see it better. Put it on the screen, please.
Sir, I have it. I have it. Can I share it now?
Yeah, sure.
Okay. So give me a minute, just.
While we are doing this, I think for all the participants, please remember what I mentioned, that we are not
লিভু এটা
always
বড়
correct.
করে দাও, বড় করে
Make
দাও।
it show, show. PowerPoint show.
Sir, is it okay now?
It's okay.
Yeah, it's okay.
Enlarge the ECG.
Yes, sir. Sir,
Ready.
just 1 minute. 1 minute, sir.
10 seconds, not 1 minute.
Sir, 10 seconds.
Got it. Okay.
Sir, is it okay now?
Yeah, it's fine.
Yes, that's better.
It's okay.
So there is Q wave in V1 to V4.
That is old
Old
anteroseptal.
anteroseptal MI, yeah.
QRS
Maybe-
complex narrow.
Maybe
Yes, complex
inferior also. Double one in part.
Yeah, there is also.
There is
LED is wrapped
fragmented-
around.
Sir, here is a fragmented QRS in lead 3 and EVF.
Yes.
Yes, sir.
I have a question for Adud.
Sir,
Will you put this question with ECG in the exam of your postgraduate class?
no sir.
Thank you. This ECG should not be shown to test knowledge of the students for the
Yes.
postgraduate students, because this will create confusion and it is not correct. However, the management is very, very important. As our friend from Nepal said, that from all the standpoint, it should be treated as ventricular tachycardia, because if we don't do that, we are harming the patient.
And this patient, is someone is asking, is the patient needs ICD? Definitely.
That's one indication.
Definitely.
That's one indication.
Yes,
Low ejection fraction.
ejection fraction less than 30% and having this malignant type of VT must have an ICD.
স্যার আমার মনে হয় যে অথবা আমরা ক্লোজ করে দিই।
Yes,
sir.
yes sir.
স্যার
Sir, will I stop sharing the screen?
Yes.
now?
স্টপ
You
শেয়ার
can
করো।
stop.
But আপনি ফেসবুকে ওই যে এতগুলা ক্রাইটেরিয়া সেট আপ করে দিয়েছে মহসিন যে চমৎকার ভাবে, সেটা কিন্তু আপনি শেয়ার করেন।
হ্যাঁ, এটা আজকে শেয়ার করবো আর কি।
স্যার মহসিন হোমওয়ার্ক এত সুন্দরভাবে করে দিয়েছে, দ্যাট ওয়াজ ওয়ান্ডারফুল।
এই সিটা স্যার।